Everybody, it's your last set of video notes for this unit. Yay! I'm sure you're all breathing a very strong sigh of relief. I know that a lot of these earlier videos involved an awful lot of differentiation of symptomology, different subcategories of disorders, things along those lines. Nice thing is that this is going to be just a very straightforward breakdown of how it is that we go about evaluating the effectiveness of those different types of psychotherapies that you were taught about. And ultimately, what are the most common ways with which people attempt to seek out help. So when we're talking about how we evaluate therapies, it's important to take a look at who people go to when they're struggling with psychological difficulties. It's not out of the ordinary, interestingly enough, for you to take a look at the fact that almost 1 in 5 individuals will seek out people outside of the profession of psychology, or even outside of the medical field. Some feel comfortable going to a clergy member, speaking to a pastor about their struggles, working to do it that way. Obviously, physicians are a very substantial number. Many people in this day and age, as we've talked about in class, they want quick results and quick fixes, and so many perceive that medications are the way to go. So if you have depression, for example, then you say something to your doctor gives you antidepressants. Wham, bam, thank you, ma'am. There's the perception that it's being treated. Obviously, we know from the conversations we've had and the information that's been provided to you, it's far more complex than just that. But for the purposes of recognizing that that's a very common scenario of people working to alleviate their symptomology, it's important to recognize how many people go to a physician. I would also take a look at the significance of how large the community of mental health experts is in this. It doesn't seem like it's that important, but keep in mind this is the largest outpatient chunk that is out there for people. So mental health specialists are around and used quite a bit when attempting to provide solutions to a person's disordered behavior. And so that's an important piece to consider. When you look at the different therapies in and of themselves that you've learned about, cognitive, psychoanalytic, humanistic, behaviorism, cognitive behavioral, family therapy, group therapy, stuff like that, what all is the most widely used? By far, it is hands down cognition. 50% of the psychotherapists out there use some kind of cognitive therapy, which is a pretty substantial number. Of surprise to kids, considering how much we kind of harp on how little scientific evidence there is out there for psychoanalytic or psychodynamic theories, it's also a pretty substantial chunk of what therapists will attempt to take a look at. But if you think about it, it's really not that big of a leap, because when we talk about the significance of psychoanalytic perspective and the effect of childhood traumas and repressed memories that people have because of those traumas that they just don't ever attempt to bring to the surface and get clarification on, it's the reality is there are many disorders we've talked about where the roots go back very, 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 very young in age. And so it's entirely possible that taking a look at those early childhood traumas and pulling them to the surface and finding some level of insight in them really can be very beneficial. So it would make sense that therapists would use those techniques. Family or group counseling sessions are also a pretty sizable chunk. And then you've got humanism and then behaviorism as well. That is like probably the smallest component out there. And that is surprising to students because it is so action-oriented. But keep in mind, just because it's a small chunk doesn't mean that there aren't still a lot of people who will use behaviorist techniques. It just means that predominantly people have found success with using cognition and cognitive therapies outweighing other options. Now, let's talk about the effectiveness of therapy in terms of perceptions, both client and therapist. If you ask a client about their therapy experiences, they have a tendency to overestimate its effectiveness. And they will tell you ultimately that their treatment was far more effective than it may actually demonstrate itself to be. It's important to recognize that there are some critiques to these perceptions. More often than not, when a client is going to be entering therapy, they're in full-fledged crisis mode. Okay, and the reality is that it is entirely possible for a patient to experience what we call regression toward normalcy, or as your vocab calls it, regression toward the mean. Clients enter therapy in that, hardcore, intense emotional state, but crises subside naturally so without any level of intervention necessarily from a therapist. So it's entirely possible that those clients had their crises resolve themselves over a natural course of time. And if that's the case, then they just went back toward, a normal everyday level of functionality. The other thing that's of importance is that the clients may need to believe the therapy was worth the effort. In their mind, it's difficult to justify going and seeing a therapist, spending $100 an hour per week, for example, to seek out psychotherapy. So they feel the need to cling to the effectiveness of that therapy and say that it was all worth it, even if maybe the end results don't demonstrate that fact. It's also important to take a look at that, once you're done, clients do tend to try to speak kindly of their therapist. So they're not going to say necessarily that the therapy that they underwent was, an effective means for them to address their issues. When you look at the perceptions of clinicians and therapists, clients and clinicians, excuse me, I can't stumbling over my words here. Clients and clinicians both have a tendency to kind of overemphasize the therapy's success. So clinicians are no different. They truly do believe that the client is better off after the reception of that therapy that they provided, rather than not getting any therapy. Now, you also have to be kind of aware of certain things and take these pieces with a grain of salt as well. Clinicians are aware of failures, but not always necessarily their own. They're far more able to pick up on those of other therapists. And they often hold a perception that if a client seeks out someone else's help, the former therapist, that first one, if you will, has a tendency to perceive that that individual has developed another psychological problem. So it's another issue that original therapist didn't necessarily help them to evaluate and attack, if you will. Clinicians are also far more likely to testify to the efficacy or the effectiveness of their therapy, regardless of the outcome. So when you're looking at these things in terms of kind of word of mouth perceptory processes, it's important to take them with some semblance of a grain of salt. That's not to say, though, that there isn't research out there that takes a look at the effectiveness of psychotherapy. And that's where another one of your vocab terms comes into play, which is meta-analysis. This is when you pull data from multiple different kinds of studies that are out there addressing this one singular issue. So, for example, the effectiveness of psychotherapy, to come to one kind of combined answer. Okay. So they do this oftentimes when they don't want to have to complete new research with participants. What they do is they're just going to look over multiple other previous studies that were done on these research pieces, and ultimately, because the pool ends up being larger with your participation base, they feel that it can provide a far more significant level of confidence in the results of the therapies, as long as you attempt to avoid certain levels of error along the way that we've talked about with regard to research ramifications. This is typically going to be done. This meta-analysis piece is going to be done when scientists want to know the answer to a question that has already been studied. They just want to kind of take a look at everybody's results, pull them together, and then see ultimately from all of those different individual research pieces, what is the answer to this overarching question. So meta-analysis doesn't happen just with psychotherapies. It can happen all over the place. For example, they can do meta-analysis on intelligence studies, for example. But it's an important kind of segue into what we're going to talk about with this outcome research here. So Hans Eysenck ended up looking at research done on evaluating psychotherapies, and he found that 2/3 of clients improved whether they got therapy or not. So he was a little bit skeptical, if you will, of the outcome of the therapies that were being implemented. But he was also a product of his time. He only studied 24 studies to look at. That's not a very large pool, all things considered. And at the time that he was most active in his career within psychology, there were really very few forms of psychotherapy out there when he was attempting to research this stuff. Now there's far more wide varieties of things. You have so many more different components to the psychopharmacology pieces, antidepressants, anti-manics, antipsychotics, for example. So today, there are hundreds of studies out there that when we look at them in terms of meta-analysis do demonstrate the efficacy of psychotherapy. So it does hold benefit. There's a lot out there that shows that almost 80% of clients who receive therapy ended up being, for all intents and purposes, far better off because of the therapy that they received rather than those who went untreated or who were even on waiting lists to receive treatment. So in general, those not undergoing therapy were able to improve, so they did demonstrate a little bit of that regression towards the mean. But those that were undergoing therapy were more likely to experience that improvement. And so that all came from Mary Lee Smith's meta-analysis in 1980, looking over almost 500 different studies. So when you look at the differentiation there between her and Ising, the amount of data is exponentially larger in Smith's results. So when you look at this breakdown in terms of these percentages, they looked to see that 80% of untreated people had less than positive outcomes than the average treated individual. So when you looked at the breakdown over here, the average client ended up receiving, a far more positive result in terms of the outcomes to their psychotherapy. So it really did end up benefiting them in the long run, rather than those who went untreated. Okay, so then that brings us to one of the big questions ultimately, which is what disorders are treated by which therapies effectively, right? So these are a couple of the different disorders and categories of the disorders. It's important to recognize I don't have all of them on here. I don't have schizophrenia, for example. I don't have, the personality disorders, and I'll elaborate on those. So let's talk, just kind of go on down the line here with what's on the slide. So when you look at depression, interpersonal therapy is very widely used and very successful, as is unconditional positive regard from client-centered therapies of the humanists. Behaviorism can also very successfully treat people with depression. And as you saw from introductions from the types of psychotherapies, Aaron Beck and all of his research done on looking at the cognitive processes of depressed patients, cognition is a very successful treatment. It's no wonder that there are so many different types of depression treatments out there, because depression is one of the most widely successfully treated disorders out there. It's also important to recognize the significance of biomedical approaches to this. Finding the right antidepressant medication to work for a patient, in addition to unconditional positive regard to different types of cognitive therapies like Albert Ellis's rational emotive therapy. So there's tons of different ways that you can kind of take a look at all of this stuff. That depression has many, many, many different types of therapies out there that are successfully capable of treating it. Anxiety is another one that's very highly well treated in terms of an effectiveness level. Cognition, obviously, you got to look at their obsessive thought processes that revolve around the things that cause them anxiety. Exposure therapy is very successful, as we've talked about. Any of the exposure therapies, systematic desensitization, virtual reality therapy, flooding. You could do stress inoculation. You could even take a look at rational emotive therapy again as one of the cognitive breakdowns for things. Bulimia, you can do a combination of cognition and behavioral techniques. So look at not only the thought processes in terms of how that person perceives themselves, but also ultimately then the maladaptive behaviors of the binging that they operate on, followed by the purging cycles for things. Bulimia is not necessarily a mental disorder we focused on here in Unit 12-13, but it is something that we learned about in Unit 8 with motivation for hunger and whatnot. So it is still of significance to mention in terms of a therapy, because it is considered to be a disorder. Phobias, not only just in the realm of anxiety disorders, they are also very well treated by behavioral techniques like exposure, systematic desensitization, and bedwetting can also be modified by behavioral techniques. Why would I pick this? It seems kind of out of left field for things. Keep in mind that is kind of a big, strong component that can connect into some of the sleep disorders that you learned about in earlier units. And it's just a really good demonstration of the fact that many of these techniques can be effective for any number of scenarios. So much of the effectiveness for something will boil down to the client in particular, and that's going to be kind of something that you'll see me wrap all of this stuff up with later on as well. You've heard me make reference to rational emotive therapy an awful lot. It can be very successful in treating personality disorders, getting the person to recognize the irrationality of their thoughts. It's very widely used in borderline personality disorder, for example. But even for somebody who's struggling with narcissistic personality, for example, getting them to recognize that it is an irrational belief that they hold, that the world cannot, work without them being around or being present. Everybody needs them. That can be a very successful treatment for personality disorders. For schizophrenia, obviously, biomedical is very significant, working with antipsychotic medications that they can find for the appropriate neurochemistry for those individuals, but then also getting the people to work things out via, various different psychotherapy techniques. Rational emotive can also be favorable for schizophrenics, working at getting them to recognize the irrationality of the hallucinatory thoughts, for example. So it's important to simply just recognize that when it comes to what therapy is best, the reality is there is no one type of therapy that's been found far superior than anyone else. Okay. There also appears to be very little, if any, connection to a clinician's experience, training, supervision, licensing, and their clients' outcomes. Oftentimes people would perceive, for example, a lack of desire to go see a therapist that's brand spanking new, that, is just coming out of school, for example, versus somebody who has an awful lot of, years and years and years worth of experience. A lot of the research that has been done has shown that matters little in terms of an ability for the client to get better. Therapy is just in general most effective when the person's struggles are clear-cut and very specific. So obviously phobias, for example, or a person's struggles with regard to depression. But that doesn't mean that it's not possible for other therapies to be able to delve into what could be possibly creating an issue and then attempting to resolve it. But ultimately, keep in mind that the whole, for many psychotherapists, the goal is tailoring the treatment to the specific issue. So as was shared with you guys at the beginning of the explanation of the different psychotherapies, an eclectic approach is by far going to be one of the most widely seen ways with which therapies are going to attempt to be implemented. Okay. It is important to recognize that there are some alternative psychotherapies out there. Your textbook does make mention to them. Things like therapeutic touch, people moving their hands a few inches from a client's body and attempting to push energy fields into bounds. Many of you guys might be familiar with this, hearing it in terms of like Reiki or things along those lines. It doesn't seem to have any scientific evidence that proves that it works. There's also eye movement desensitization and reprocessing. This is when people basically attempt to try to remember traumatic experiences that they had. And what you do is you try to get the person to move their eyes back and forth while remembering that traumatic experience to make a person become, less sensitized to that stimuli and to those thought processings. But again, there's just not really much evidence out there that supports that these guys are of benefit. One alternative therapy out there that has shown some promise is something called light exposure therapy. And this goes with a depressive disorder out there called seasonal affective disorder. You're familiar with it as the winter blues. This is when people just feel a lot less active and energetic and engaged because of the winter months, because they're not getting as much light. And the sun gives off lots of vitamin D and things like that, and that obviously can have a very significant impact on your mental health. When like when it's nice and bright and sunny and warm out, you want to get outside, you want to be active, you want to go. When it's cold and rainy and snowy and stuff like that, you have no desire to do that. And so if it's severe enough, it can be diagnosed as seasonal affective disorder. But this has been shown to be successfully treated to some extent with light exposure therapy, where person goes and they sit in front of some UV rays to get that light exposure, and that does seem to kind of help boost their levels, so to speak, to kind of get them out of that winter funk and feel more engaged and energetic and feel happier. Now, let's talk therapists and their training to look at this evaluation of psychotherapies in general, and this is going to kind of wrap things up. You've been presented since day one with the different types of therapists out there. There's a clinical psychologist, counseling psychologist, psychiatrist, stuff like that. So where are most therapists kind of coming from? Where's their background? Where's their training? Lots of them are going to be clinical psychologists, so they've got PhDs predominantly, or PsyDs, so they've gotten a doctorate in psychology. They're going to be experts in research and assessment and therapy techniques, but they can't prescribe medication, so they're not going to go that route. They're going to do an awful lot of like cognitive retraining or behavioral techniques. You could be clinical or psychiatric social workers, where you've got, maybe a master's of social work, postgraduate stuff. If you are a psychiatrist, you have a medical degree. Okay, you are a clinical doctor. But most of those psychiatric social workers aren't going to go to that extent. But some social workers can offer psychotherapy. They're mostly going to help people with everyday kinds of problems. Counselors in general, these are going to be people that work with scenarios of connections to family relations, possible struggles with substance abuse, things along those lines. Counseling psychologists can also have PhDs or PsyDs. They'll have some aspect of graduate school work. And then, as you heard me say, psychiatrists, they're medical doctors. So they're going to work with predominantly the specialized and severest of severe cases. And they can treat with medication. So they can incorporate that into their kind of eclectic approach to the therapies that they provide. So one thing that is often kind of tossed out there is it possible to prevent psychological disorders? The reality is that to many within the field, you can prevent psychological disorders, but you have to take out an awful lot of the unpleasant realities of what our society puts out there. Poverty, heightened levels of criticism and critique, high levels of unemployment that can lead itself towards stress and depression and a sense of hopelessness and worthlessness. There are, strings of racism, sexism, ageism, any number of the negative social aspects out there can ultimately lend toward creating psychological disorders. So is it possible to prevent them? In theory, sure, but it's in many respects a utopian dream to hope that these kinds of things can ever possibly be eradicated. As we're going to talk about in Unit 14, stereotypes in and of themselves are, while good or bad or neutral, that's up for debate for a later time, they do seem to be kind of hardwired and programmed into the brain, and naturally so. So it does beg the question of whether it's ever even possible to stop things like stereotyping based off of race, gender, sexual orientation, et cetera, et cetera. So it's certainly a very lofty goal. We'll put it that way. Okay. Different kinds of mental health programs that are out there. That also has a tendency to connect back to certain aspects of social conditions. We've discussed an awful lot about, the significance of labels when someone is attempting to seek out help and treatment. To have to identify that, to put a label on it, means that a person is different. And so advocates of preventative mental health programs argue that an awful lot of the disorders that they see are due to social conditions that are out there. And so to prevent the disorders, we've got to change some of these societal constraints and try to foster growth and self-confidence rather than working to kind of tear people down. So at the end of the day, when you look at even just different therapy techniques, you're presented with this biopsychosocial component, once again, in terms of successful intervention to ultimately address and support someone who is working to end up addressing their particular struggles. For the sake of trying to keep this a little bit brief, I'm not gonna spend a ton of time focusing in on each one of these different subsets. My take on it is that you guys can pause this and read it at your own leisure. But ultimately, this is going to be where we're going to end it, with this focus on the fact that successful treatment for an individual seeking out disorders or seeking out help for disorders is all going to stem back to a multi-pronged, multifaceted approach, and no one therapy is better than the other. So this is the end of your Unit 12-13 content. You are about to move into Unit 14, which is the very last unit that you will ever have to take content on for me. So deep breaths, big sighs of relief. We are almost there, guys.